And then as soon as it looks like we've got all the folks in here, we will get started. If you are comfortable taking off your or putting on your video and being part of our conversation today, we love that. We also understand that folks may be in transit or doing different things. So if it's not feasible, that's fine, but it's always nice being able to look at the individuals who are here with us today.
Yeah, and if you all don't mind, in the chat box, signing in with your name, email, and county, please. Thank you.
All right, thanks so much, everyone. I think that we have reached steady state here. So welcome to this Region 9 sponsored doula support training. I'm Alex Peel. I'm an OBGYN and a health services researcher at the University of Michigan. I'm also the Region 9 lead for the opioid and substance use work group. I have a couple of folks from Region 9 here with me who may be familiar to y'all, Avonlea, as well as Helen Allen. I also have some folks from my Partnering for the Future team, which is the clinic that I direct with Dr. Maria Music. So you'll see Sarah No back here. And then my co-presenter today, Julia Erickson, who supports some of our work out of PFF and is also a practicing doula herself. We're so excited to see your introductions in the chat. And I'm going to go ahead and bring up the slides and get started, unless there's anything else from the Region 9 and PFF team that you'll want to start with. All right, very nice. I just want to share some quick disclaimers with everyone today. We are going to be covering some content that may be potentially sensitive to individuals. So please pay attention to yourself, your needs, and contact any necessary support networks. If you need help finding those resources, please feel free to use our contact information, and we're happy to support you. Look out for the light bulb throughout this presentation. These are moments to reflect, to check your own bias, to check your own experiences. Unfortunately, today's 1 hour session doesn't allow for sufficient time for us to fully discuss those reflections, but we hope that you'll bring those back to your friends, your communities. With that, if you would like to stay after today's session for a 30-minute discussion with Julia, we would love your feedback. This is a pilot training to see which areas of content speak most to you and most support your practice. So please, if you're able to stay after, great. If not, we will have a quick survey where you can provide that feedback asynchronously. And yes, we hope this is the first step in many in helping to support this really important group. So we're going to start with a little bit of background, specifically why opioid use disorder in pregnancy is such an important topic. So right now, we are in the midst of two concurrent crises in the United States. The first is the opioid crisis, with hundreds of thousands of deaths due to overdose. And we have seen that spill over into pregnancy with increasing rates of opioid use disorder and neonatal opioid withdrawal syndrome, which we'll go over more later in the presentation. We also are in the midst of a maternal health crisis with the highest rate of maternal morbidity and mortality of peer nations and significant inequities in access, experience, and outcomes. And these two crises collide in the #1 cause of pregnancy-associated mortality in Michigan and the leading cause nationally, and that is overdose related to opioid and substance use disorder. Just to put a point on it, almost a third of pregnancy-associated deaths in our state are due to opioid and substance use disorder. So if we want to improve outcomes for birthing people, this is a critical area to address. We have seen a bit of a transition in the face of the opioid crisis over time from heroin transitioning to other synthetic opioids, including fentanyl in more recent years. These opioids are more potent and have a higher risk of overdose, and so really change the care, and support that we need to provide our patients. Similarly, we've seen an increase in postpartum deaths related to opioid use disorder, and the majority of mortality in this space occurs after birth. So just important for us to think about our support systems and the structures that we have in place. Opioid and substance use disorder in pregnancy and the postpartum period can have significant effects on both the mom and the baby. Certain substances, like alcohol, can result in structural anomalies in the neonates. We can also see pregnancy complications like growth restriction, abruption, preterm labor, stillbirth, and afterbirth neonatal withdrawal. Substance use also has effects on people's ability to access prenatal care and their engagement with high-risk activities that can lead to higher risk of infectious disease, trauma, and mental health concerns. And mental health concerns really sit at the intersection of opioid use disorder and some of these complications and can be both a source and an effect of substance use. The positive thing is that many of these adverse outcomes can be mitigated through routine prenatal care and treatment for substance use disorder. While today's presentation focuses on opioids, I do just want to highlight that many patients will have polysubstance use or may have other substance use in pregnancy that's important to address. Many of the principles of care apply to any substance use disorder, but we will focus on opioids today. And this slide just gives you a sense of other substances that may be considered and their pregnancy-specific effects. So, opioid use disorder is treatable in pregnancy, but it requires a couple of steps in order for us to accomplish that. First, it's hard to manage what you don't measure, so we need to identify substance use in pregnancy. Second is to understand the comorbidities and contributing factors to someone's substance use, including mental health conditions, as well as trauma and social drivers of health. Next, with permission, we want to share options with patients and help them connect to those kinds of services. The mainstay includes psychosocial supports like 12-step programs or Narcotics Anonymous, as well as peer support, group, and individual therapy. For opioid use disorder and some substance use disorders like alcohol, we do have pharmacologic options that are safe and effective in pregnancy. And then finally, making sure that all of these pieces fit together, that folks have wraparound services, is critical for improving health. All of these things can help patients to engage in routine prenatal care, which can reinforce those treatments. And then finally, making sure that we maintain close contact and follow up with patients so that we are their supportive network is critical. I mentioned comorbidities. These play a huge role in both the initiation of substance use, the development of substance use disorders, and then their treatments. We see huge overlap between substance use and trauma, with 80% of patients with substance use disorder who are pregnant reporting some history of trauma. We also see high rates of mental health diagnoses. About 85% of patients in our clinic, where we see patients, report a concurrent mental health history. And these traumatic events can begin in childhood with adverse childhood experiences and then be perpetuated later through community events, really creating both a difficult foundation for managing these mental health and traumatic events and for overcoming them. I just want to add that politicization of addiction can really limit access to care and create challenges. We have seen criminalization of opioid and other substance use disorder in pregnancy. Over 25 states and Washington, D.C. consider substance abuse in pregnancy child abuse. You can see the potential limitations that could have on folks being able to access and engage in treatment with that kind of criminalization. The discussion around abortion and fetal personhood certainly influences that. We have seen that changes in abortion laws further legitimize criminalization of birthing people with substance use disorder, which we consider a chronic condition, not a criminal action. And then finally, reinforcing stigma really limits patients' ability to access and engage in treatment in pregnancy. We see a close relationship between passing of legislation in these spaces that criminalize substance use in pregnancy and individuals' ability to access and engage in care. In Michigan, our laws do require the report of suspected child abuse or neglect if there are symptoms or suspicion of alcohol or controlled substance in the newborn. And so this can be complex And often folks on the front line, nurses and physicians, have questions about this care, and we encourage them to reach out to either our team or the pediatrics team here at Michigan Medicine to help with interpretation of these statutes. I just want to read this quote because I think it really highlights the unique challenges of birthing people in the United States with substance use disorders. Contrary to claims that arresting and prosecuting pregnant people will encourage them to desist from substance use and thus improve maternal and fetal health, fears of detection and punishment present a significant barrier to care, causing some people to delay or avoid prenatal care altogether, which creates a health risk. So our job as support people for patients, and particularly in your role as doulas and advocates, is to help pregnant patients feel safe and access the services that they need. With all of that context, it is not surprising that the number one reason that birthing people with substance use disorder do not seek out care and services is fear. Fear of mistreatment, fear of not being treated with respect, fear of criminalization, and fear of not being able to parent their children. So with this in mind, I would like to go over briefly some general principles that we employ at the Partnering for the Future Clinic and are particularly important in the care of birthing people with opioid and substance use disorder. I recognize that many of these may be your bread and butter as doulas, and if these are newer concepts, then we can point you to resources to do a deeper dive in the future. These three principles include using words effectively and to minimize bias and stigma, using a trauma-informed approach, and harm reduction. Words really matter when caring for birthing people with opioid and substance use disorder. Some of the language that's historically been used, like addict or saying that someone who returns to use is dirty, can perpetuate bias and stigma in this environment. This chart provides some helpful language for things to use and not to use, and how this can create a more person-first approach to care. A few additional language pieces that I wanted to mention. Often it's said that people with opioid use disorder are hard to reach. Shifting our language to hardly reach puts the onus on us to reach out and make sure that we're connecting with folks. We've often said that people are on Suboxone, which is a medication for opioid use disorder and is evocative of substance use or painting that medication use in a negative light. Talking about patients receiving medications instead can help to reduce that bias around medication. Here are some helpful phrases from the SAMHSA Harm Reduction Toolkit that I find helpful. Instead of saying, if you loved your children, you'd stop using, you can start with a more positive framing. I know you love your children. What can we do to help you parent them the way you want to? And these resources will be provided at the end of the presentation in case you want to take a deeper dive. Trauma-informed care is a key component of the Region 9 initiatives, and Deb Reisel has done some beautiful work promoting this across the collaborative. We just wanted to briefly highlight it here. As a reminder, trauma-informed approaches realize the widespread impact of trauma and understand potential paths for recovery. It includes recognizing the signs of symptoms of trauma in clients and responding by integrating knowledge about trauma into policies, procedures, and practices. Going across the 4 steps of trauma-informed care, there are multiple ways that this can be incorporated in clinical practice, in your practice as a doula, realizing trauma is widespread through training and recognizing and identifying those traumatizing aspects of care, things like pelvic exams or cervical checks in pregnancy. Recognizing symptoms of trauma in patients. This is a place that as doulas, y'all can be particularly effective in helping to communicate that to the care team. Responding to that trauma by fully integrating trauma-informed care into policy and building safe environments. And then finally, avoiding perpetuating trauma through including patients and community members in our care planning. The final principle I wanted to address is harm reduction. And I will say, as a physician, this has been a big frame shift for me. I was trained to get people to do the right thing. But instead, harm reduction really shifts the conversation to getting people to come back safely and to remain engaged in care. We'd like to say that recovery work is not all or nothing. In the Partnering for the Future clinic, we have patients who are still in active substance use and come in and receive recommended screenings and prenatal care with us to help optimize their care as much as they are able. Meeting patients where they are can help open up doors for recovery in the future and help folks to be safe while they are continuing to be in active use. Here you can see some examples of harm reduction. Things like not using alone, avoiding using substances together, continuing to take care of your body even when using substances, or thinking about transportation and childcare. So as I said, recovery is not all or nothing. There are lots of ways that we can help folks to be safer and continue to meet with us. So with that background in mind, we would like to move into some examples of how doulas can provide prenatal support. Doula support in our conversation today is going to be organized by time. We'll talk about prenatal support, support during the labor hospitalization, the immediate postpartum support while patients are still in the hospital, and then moving on to long-term postpartum support once the patient comes home. We recognize that you may not practice across all of these settings, but we hope that it'll provide important context and will provide a little bit more information on each of these phases as we go. So I'll hand it over to Julia, who will start us off with case one.
Fabulous. And I will preface, as Alex did earlier, each of these individual kind of time points could be an entire talk and training in its own. Today is a pilot, as we've mentioned, so this may feel fast. That's on purpose. We want to get through everything. Just know that we're working hard to get additional materials out to you guys as well. It's our goal. So the way that this is going to be organized, we're going to talk through one case per time point as a way to kind of frame set everything. So we'll start with Jessica. She is 28 years old and is 12 weeks pregnant with her first baby. She's attending her first prenatal appointments and has been receiving Suboxone to manage opioid use disorder for the last year and a half. She is so thrilled about this pregnancy, but also anxious about her providers are going to view her history of opioid use. For the last few weeks, she has been so nauseous that she's had to call out of multiple shifts at the restaurant she works at. She's really worried about maintaining her job and is uncertain about if she will be able to afford gas money to make it to her next appointments. She's had to skip a few Suboxone doses because of her nausea, and her cravings for opioids have returned, though she has not returned to use. She's at this first appointment, and her provider collects a urine sample and runs a urine drug test before they discuss what that actually means. When it comes back, the sample shows no evidence of opioids since Suboxone is not detected on urine drug tests. However, her provider returns, and Jessica immediately feels like something is wrong. Her provider assumes that she has stopped taking her Suboxone as prescribed and is worried that she is selling it to others. So I want to take a few moments for what we're going to do is silent reflection, although I'd love to hear the thoughts from everybody in this room right now. Just think about these following few questions as we run through our next few slides. What assumptions did the provider make about Jessica's Suboxone use, and how can I, as a doula, remain aware of potential bias, although it may be unconscious, in myself and other people while working with clients? How do you imagine stigma has shaped this client's relationship to healthcare and parenting? And how can I create a trusting and non-judgmental space where Jessica feels comfortable expressing her challenges, such as the nausea and discomfort she's feeling, the worries about finances, and the fears around stigma? And as Alex said, please feel free to share thoughts in the chat if you'd like. Okay, I think we're going to go ahead and tag team this a little bit to talk about what we can now expect in a situation such as Jessica's.
So when a patient like Jessica comes in for routine prenatal services, we can expect to help her complete recommended screenings, laboratory tests, immunizations to help her have a healthy pregnancy. If Jessica had not already identified her opioid or substance use disorder, we would complete screening and diagnosis, and then discuss appropriate treatment options and referrals for her she already has care established, but for patients who didn't, we could help them to initiate therapy as they are ready. We'll also make opioid use disorder specific recommendations for pregnancy, additional infectious disease screening, management of any sequelae of opioid use disorder, including IV drug use, and then recommendations for antenatal testing later in the pregnancy.
And then as the doula, in addition to everything else that a doula is doing, we are going to support this access to routine prenatal care, while also advocating for the patient's consent with urine drug testing, making sure that they understand what this means, that consent is always in the hands of the patient. And then support the patient through treatment selection and initiation, and working their desires and their experiences into a birth plan to use that as a communication tool throughout this prenatal period and the actual birth itself.
We wanted to go over a few of the clinical nuances that can help provide context to that supportive role that the doula can play for patients during their prenatal care. The first is discussing urine drug screening versus testing. So screening is done verbally as a series of questions asked about the patient's substance use. This is recommended by the American College of Obstetricians and Gynecologists and other leading maternity care organizations for all patients. This can help to identify opportunities to support patients and intervene, and can also reduce inequities in urine drug testing. Urine drug testing, in contrast, is a method to detect and confirm substance use, and this is commonly done through urine. Urine drug testing should never be done without a patient's consent and sharing the implications for the patient. And specifically, those implications include potential CPS involvement in the patient's postpartum course, as substance use in pregnancy can be considered a potential issue for parenting. There are a variety of screening tools that have been validated in pregnancy. At the University of Michigan, we use the NIDA Quick Screen, which we have adapted for pregnancy, which is really a snapshot of the patient's current and recent substance use. Other centers use the 5 Ps, which you can see here on the other side of the page. The most important thing is that screening is done in a resource-first way, sharing with patients why this screening is being done and what will happen with a positive screen, and that it's administered to everyone in a respectful way. So why do we screen? Because we can help patients with treatment. For patients with opioid use disorder, medication is considered the evidence-based effective treatment for helping to prevent overdose and death. Patients who receive medication for opioid use have lower return to use, improved outcomes, and increased engagement with prenatal care. Very few of that interventions in medicine can we point to that are 97% effective. When we talk to patients about medication for opioid use disorder, we reflect that this is not replacing one drug with another, which is commonly what patients will hear from partners, from friends, and from others in the healthcare system without training in this space. We use a chronic disease model of substance use where we talk about medication the same way that we would for chronic hypertension or diabetes. We provide anticipatory guidance about how medication needs change in pregnancy. Often patients may require dose adjustments throughout pregnancy with the increase in pregnancy metabolism. So return of cravings or withdrawal symptoms is not a failure of the patient, but rather an expected change in physiology that must be addressed through medication titration. We have a lot of conversations about the safety of medication for opioid use disorder for the infant. The best known sequelae of medication for opioid use disorder is neonatal opioid withdrawal syndrome. This is a constellation of findings including increased irritability, GI upset, that can be seen in newborns born to mothers exposed to opioids in pregnancy. Neonatal opioid withdrawal syndrome, or NOWS, is short-term and it is treatable. We'll talk about that in the next few slides. And patients receiving medication for opioid use disorder are more likely to have healthy term infants than those who do not receive treatment. Finally, the dose of medication for opioid use disorder is not related to the rates of withdrawal. And this is often counterintuitive. We think if we just reduce the dose of medication, maybe baby will experience less withdrawal. So I often see patients who have self-titrated down on their medication in hopes of seeing less effects in their babies. This is actually not true. We believe that opioid transfer across the placenta is mediated by receptors that are independent of the dose. And so we should be adjusting the medication to patients' needs, cravings, and withdrawal symptoms, not to some arbitrary lower limit to benefit the baby. Here on this slide, you will see the 3 most common types of medication for opioid use disorder in pregnancy. Methadone and buprenorphine are used most commonly, with emerging data on the safety of naltrexone. How these medications work is slightly different, and the forms that they're available in also differs. Methadone is available in a tablet and a liquid and must be administered by special methadone clinics. It cannot be received at a routine retail pharmacy. In contrast, buprenorphine is taken by the patient in their home, is prescribed and managed by routine pharmacists. Naltrexone can also be prescribed outside of a medication treatment center. There are some unique considerations. We'll go over more of those on the next slide. But here is just a basic overview to let you know how these medications are delivered and where. Some patients may benefit from methadone versus buprenorphine because the requirement to go to a clinic provides additional structure to a patient's day. There can also be additional recovery services available at that point of medication. So for some folks, this can be a really positive approach to their recovery. Additionally, the dosing of methadone can provide some benefits in a time where our opioid supply is more potent. In contrast, buprenorphine is much more convenient for patients, can be taken at home or wherever they are. There is some early data potentially showing reduced congenital malformations with first trimester exposure. However, those studies are unable to adequately account for the differences in patients who are receiving buprenorphine versus methadone. The other benefits for neonates, including lower rates of neonatal opioid withdrawal syndrome, do not have sufficient data to support switching from one medication to another. So the choice for which agent for treatment should be based on the patient's experience. And if they enter pregnancy on one agent, they should continue that through the pregnancy episode. I think this quote really summarizes it best. Patients usually know what the best treatment is for them. The ultimate treatment decision must be the result of shared decision-making between a knowledgeable clinician and the patient. So why not do medically supervised withdrawal? This is where patients stop their substance use, have supervision to transition out of that acute withdrawal period, and then continue without any support. First, withdrawal in isolation may be associated with higher rates of miscarriage and preterm birth, so this is not the safest option for our patients. Proceeding without medication treatment is also associated with a higher return to use rate, 60 to 90%, and with that, lower engagement with prenatal care. This return to use can be associated with infectious disease, accidental overdose, and other obstetric complications. So medication for opioid use disorder, whether that is with methadone, buprenorphine, or naltrexone, remains the mainstay of treatment for opioid and substance use disorder in pregnancy. So for patients who have opioid use disorder, we modify their prenatal care delivery slightly. We do additional infectious disease testing for those who have IV drug use or other behaviors that put them at risk of exposure. We also recommend additional antenatal testing starting at 32 weeks. For those who continue to have active use, we recommend twice weekly non-stress tests. In the active use population, this can be a little hard logistically to operationalize. And then for those on medication for opioid use disorder, weekly testing. We recommend a growth ultrasound in the 3rd trimester for everyone. And just note that these recommendations may differ a bit if folks have additional complications. We do hear from our patients that the timing of their non-stress test and antenatal testing can be a time where they experience shame and blame for their receipt of medication or their ongoing substance use. And so this can be a great opportunity for advocacy.
Great. So as we come, given all of that information that you guys have just received, we'll revisit Jessica's case just to see how doula support can be helpful and potentially benefit Jessica in this situation. We can go to the next slide, and we have some points on where doulas are in action. A lot of this will likely sound familiar to many of you. I'll also note that I know many, specifically birth doulas, rarely are in contact with a patient this early in pregnancy. Could be motivation to encourage clients to seek out that support earlier if that's feasible for them and for you. But by partnering with Jessica early on in this pregnancy, you offer some additional support that can help her feel more confident going into that first appointment, understanding her needs and her preferences, connecting her with community resources and more practical resources such as gas cards to support access to care and to help minimize those barriers that she is worrying about. You can help Jessica call her Suboxone provider to discuss her symptoms that she's feeling and the reasons why she's been missing doses or feeling like this is not feasible at this time, identifying different ways that she can take her medication to ensure that she is staying up to date on that treatment in a way that feels good for her. And then also helping Jessica ask questions at that appointment about urine drug testing, knowing that helping her understand that her consent is not implied, that she must give that consent before they can run any of these testing options. And also understanding that screening is often done universally, that is not necessarily a point of bias or stigma in her providers, hopefully, but that it's a tool used by doctors that is hoping to minimize risk all around, not just in her case. So we'll move on to supporting patients in labor now with another case study. Here we have Caroline, who is pregnant with her third baby, and she's in labor. She has been admitted to the hospital. She has her partner with her and her doula with her for labor support. Her doula has worked with her prenatally and is familiar with her needs and her desires. She has a history of opioid use disorder, but has been successfully using medication to help mitigate that for the last 3 years and has had no return to use. She's worked with her doula to create a very detailed birth plan, which explains that she would like an epidural early in labor for pain control. When she gets to the hospital, she gets that epidural exactly how she wants, but her pain is very poorly managed, and she is having difficulty coping with the contractions and the discomfort. She expresses to her doula and her provider that she needs additional pain control. When Caroline's doula steps out of the room for a minute, she overhears the doctor talking to a nurse and saying that Caroline is likely just seeking drugs while she still has the chance. So take a few minutes now, either privately or you can note some thoughts in the chat if you'd like. In what ways do I, as a doula or as a birth worker, feel entirely prepared to support a client in this situation with substance use and in labor? And where do I feel less certain? Where in this situation do I feel a little bit uncomfortable? How could I seek the appropriate resources, training, mentorship to help me feel confident in these situations? Being in this room right now is a wonderful first step for everybody. How could Caroline's birth plan be used as a tool to share her pain management desires with her provider team? And in what ways could a doula step in here to help de-escalate this situation while honoring the patient's lived experiences and also respecting the care team's clinical perspective? We're not trying to create tension. We want to de-escalate that situation, something that doulas are very familiar with. So what can we expect here?
So for the clinical team, Their job is to provide medical services to help have a safe labor and birth, including monitoring the patient, the baby, and fully assessing pain. Clinical teams should continue medication. I'm just going to help someone to go on mute. Great, thank you. We will continue medication for opioid use disorder throughout the labor, birth, and postpartum period, and help to support peripartum pain, making adjustments to the plan as needed.
Yeah, and then as a doula, you'll be providing labor and birth support, as we are also very good at. Incorporating that trauma-informed approach that we mentioned earlier, supporting non-stigmatizing treatment and language, and advocating for the patient's pain management needs. As Dr. Peel is going to talk about in a second, this may look different for someone like Caroline or someone in her situation. How can you as a doula be an advocate in that situation and always?
I wanted to take a moment to highlight how pain management is a bit different in patients with opioid and other substance use disorders. And these principles apply to the prenatal period, the birth, and the postpartum period. Patients with opioid and substance use disorder have differences in their opioid receptors, and this is both from their substance use as well as the medication that we use to treat it. For these reasons, pain may be difficult to control, and patients may require additional medication than folks who do not have these comorbidities. It is critical that patients continue their medication for opioid use disorder throughout the birth and the postpartum period. Stopping these medications abruptly will lead to withdrawal, which will make patients uncomfortable and can have negative effects on them and their experience. And as I mentioned, with that medication, folks may need additional opioid medications to control their pain. It is critical to remember that poorly controlled pain is a risk factor for return to substance use, for adverse mental health outcomes, and poor maternal-infant health bonding. There are a few medications that patients receiving medication for opioid use disorder should not receive. These are less commonly used now, butorphanol, but that medication, also known as Stadol, will precipitate withdrawal. So important to avoid this. As doulas, y'all are uniquely positioned to support non-pharmacologic strategies to help individuals cope during their labor, and these can be incredibly helpful adjuncts to the pharmacologic therapies that are used. At times on labor and delivery, urine drug tests are administered to birthing people with opioid and substance use disorder, helping to advocate for the patient, make sure they're aware of this testing and are able to provide their consent is important in these spaces. And as Julia so nicely mentioned before, many patients experience trauma, and the birth episode can evoke many of those prior experiences. So being aware of any traumatic history and helping to support the patient throughout that process can be impactful. Here's a quote from interviews that we did with patients. These were from a national sample. And this patient had opioid use disorder and reflected on pain management in her birth experience, which was quite similar to Caroline's. She uses the term addict, and so that's reflected here. So I think also with being an addict, a lot of times hospitals think you're drug seeking when you're telling them you're in pain and you need something for it. For example, during my pregnancy, my epidural came out and they didn't believe me. Then finally, after hours checking, they realized my epidural came out and I felt like I was being treated, like I wasn't being taken seriously. And they just thought I was trying to get drugs, even though I've been clean ever since my pregnancy.
So as we come back to Caroline's case with these points in mind, we'll talk a little bit about where her doula steps in. She came in with a doula and was prepared with that birth support. Caroline's doula provides that physical support, those non-pharmacological interventions that we are, as Alex said, so uniquely positioned to be using here. You're advocating for Caroline's comfort. You are ensuring that her voice is heard and that she feels comfortable and empowered to speak up and to voice the pain that she's feeling to her providers. And as mentioned earlier, just helping to de-escalate any situations where providers place blame on Caroline for her pain and her discomfort. And helping facilitate those conversations in a healthy and productive way. So moving on now to the immediate postpartum period. And when we say immediate, we're really talking about this first 24 to 48 hours, as you'll see in this case here. So Jamie here is 25 years old and had an emergent C-section at 37 weeks for her baby's heart tones. She has continued active heroin and fentanyl use in pregnancy and is practicing harm reduction, including using clean needles, not using alone, and engaging in prenatal care. She's uncertain if she wants to parent, and she is 24 hours postpartum and still admitted to the hospital. Due to her active use, her doctors are only offering acetaminophen as needed. However, she is experiencing a lot of pain at her incision and is not able to stay comfortable. She has repeatedly asked for something else to help her manage her pain, but her doctors are refusing to offer anything other than acetaminophen. Her baby boy is in the NICU because he is showing signs of neonatal opioid withdrawal syndrome, which is also called NOWS, as we mentioned earlier. They will not let her see her baby, and she's barely able to get out of bed because of her poorly controlled pain. So some notes of reflection here. How can I, as a doula, validate Jamie's pain and emotional experience, particularly when she's likely feeling dismissed or stigmatized in these situations? How could a doula help facilitate respectful, non-confrontational dialogue with her care team to press for appropriate pain control and withdrawal? And then how can I, as a doula, help Jamie bond with her baby while he is in the NICU and she is focusing on her pain management? As we mentioned before, Jamie is uncertain about her desires to parent, and she is trying to figure that out in the midst of all of these other things happening at the same time. So what can we expect in this situation?
Well, team, it is my job to help manage Jamie's postpartum pain and support her healing from her cesarean birth, detect any complications, and make sure that we're managing that appropriately. Jamie will likely begin to experience symptoms of withdrawal with her abrupt discontinuation of use with her hospitalization, and this can be an important opportunity to offer medication for opioid use disorder and begin her path to recovery, or offer additional services to help support her withdrawal experience. It is also my job to help make sure that we are supporting her infant, and we can do that with the Eat, Sleep, Console program, which we'll introduce momentarily.
Yeah, and then as the doula, it's a lot of the same that we have been doing throughout so far. So supporting these conversations about pain management options, advocating for Jamie's postpartum recovery needs, understanding that this could look different for her as someone who not only has a history of opioid and substance use, but is actually currently using and likely experiencing lots of discomfort from the abrupt withdrawal with her admission to the hospital. And then supporting the patient in enacting Eat, Sleep, Console and knowing what that means, what to expect, and knowing to ask for it when she's in the hospital, which we'll talk more about very shortly.
Postpartum pain management is ideally done with a team approach for people with opioid and substance use disorder. As we mentioned, their pain can be more complex to manage, and involving experts in addiction medicine, anesthesia, and even pain specialists can help to make sure that additional management strategies are available. This can include things like long-acting opioid medication in the epidural, which is not experienced systemically in the same way that parenteral opioids are. This can also potentially include regional blocks, things like top blocks, which go between the muscles of the abdominal wall or the layers of the abdominal wall to help provide longer lasting relief. The mainstay of treatment for any patient with pain after birth is scheduled over-the-counter medications with acetaminophen and ibuprofen. This also holds true for birthing people with opioid and substance use disorder. Patients with these conditions may benefit from IV nonsteroidal anti-inflammatories or IV forms of medications like ibuprofen. Most commonly, ketorolac or Toradol is used in the inpatient setting. Patients may need opioid medication postpartum, and it is reasonable to prescribe small prescriptions with close follow-up to help patients manage pain effectively. Remember, poorly controlled pain is a risk factor for return to use. It's helpful to discuss patients' preferences and expectations. For those who have a history of opioid use disorder related to opioid pills, this may be an experience that is challenging for them, and helping them to think through what this will look like and how they'll keep themselves safe can be important. And we've said this multiple times in this presentation, but critical to continue medication for opioid use disorder if a patient is using it, or to explore starting it if that is a new feature of their potential recovery. This QR code here will direct you to a series of postpartum pain management resources, including patient and provider-facing resources. These have been developed through an FDA-funded grant to develop new national guidelines for postpartum pain management, and do also include a segment on complex pain, including pain management for birthing people with opioid and substance use disorder. Here's an example of a patient handout to help support shared decision-making around selection of a variety of postpartum pain management considerations, including the use of non-opioid medications, non-medication options, and selecting the right opioid medication prescription size if appropriate. This is just a little more information on those new postpartum pain management guidelines, the comfort guidelines, which you can find linked with that QR code. We wanted to touch briefly on neonatal opioid withdrawal syndrome. This is a syndrome experienced by infants shortly after birth due to in utero exposure to opioids. It's important to note that this is withdrawal, not addiction. Addiction is a pattern of behaviors that result in adverse outcomes for patients in their relationships with family, their work conditions, increasing use in spite of similar effects. Infants who are just born are not capable of exhibiting those behaviors. Rather, it is a physiologic dependence that we see because of exposure to the opioid. The timing of neonatal opioid withdrawal, or NOWS, depends on the opioid that the patient was utilizing. With heroin, it can be seen in the first 24 hours, methadone up to 72 hours. And so for this reason, we tend to observe patients and infants for 72 hours after birth to assess if they will experience this syndrome. There are a variety of symptoms that babies can experience. I often say to patients, it's just like having a fussy baby. And rates are greater with methadone, which can be up to 80%, than with buprenorphine, where the range is typically 20 to 40%. We used to use a very complicated scoring system to assess infants' withdrawal and then manage with opioid pharmacologic therapy. But in recent years, we've transitioned to the Eat, Sleep, Console program, which uses the stoplight scoring system on the right. So babies who are in the green are coping well. In the yellow section are showing some signs of withdrawal, and then in red may need more assistance or intervention. And in the Eat, Sleep, Console program, we let parents do what they do best. We help feed the baby, help them get to sleep, and help provide comfort. This is an incredibly effective intervention, which has shown a decrease in time to discharge by almost 7 days with equivalent safety outcomes. And we have a series of resources that have been developed by Mott Children's, which you can access here.
I was still on mute. Thank you. So coming back to Jamie's case with these things in mind, where can and does her doula step in? There are multiple ways. We can go to the next slide for some points. So as this, sounds like I'm beating a dead horse, but advocating for Jamie's pain management and withdrawal needs in all cases and all situations. A doula may be a familiar face to Jamie, someone that she's comfortable around. So going to visit Jamie's baby in the NICU if the hospital allows, and sending her photos, videos, just ways to help her feel connected to that baby if that's what she wants. Advocating for the Eat, Sleep, Console model, helping Jamie understand what that means, ensuring that her providers and Jamie are on the same page by facilitating that conversation. And then maybe connecting Jamie with a postpartum doula or additional postpartum support so that she can continue to recover in whatever way that means for her. And if she chooses to bond with her baby, if she chooses to not parent, help her navigate that transition by either connecting her with someone else, or if you have the tools and resources yourself, being that comfort person for her. I see someone in the chat connecting her with a lactation consultant as well. Absolutely. And we're going to talk more about breastfeeding momentarily. So moving into that longer term postpartum support, we have Laura, who is 5 days postpartum. She is home now and she's delivered her second baby girl. Before getting pregnant, Laura sought management for opioid use disorder and started medication to help. She successfully continued her medication throughout all of pregnancy and her postpartum period so far and has maintained recovery. Her mother is staying with her for a few weeks since her partner did not get any parental leave, and so she needs a little more support. Laura's mom tells her not to breastfeed. She says because of the medication she's on, it's not safe. She's overwhelmed because of her 2-year-old daughter is not adjusting well to the new baby in the house, and she's not getting much sleep. She's experiencing more pain than she was expecting. She calls her doctor's office to explain the situation, hoping for a little bit of support. She asks for help managing her pain so that she can take care of her family. Her doctor says that this is just normal postpartum stuff and it will get better with time. She is exhausted, she's frustrated, and she's uncomfortable due to the pain that she's in. She's having a lot of trouble coping, and she returns to opioid use. So what kind of practical resources could Laura benefit from here to start? How could a doula help connect her? What resources are we aware of? What resources do you need so that you can support these clients? Laura's doctor says that her pain is, quote, just normal postpartum stuff and refuses additional help. Where's the bias here? How has misinformation from her mom and her doctor about opioid use disorder and treatment affected Laura's care? So, yeah, go ahead.
Yeah. So, as the clinical support team, it's our job to help keep Laura safe in the postpartum period. ACOG recommends seeing the patient within 3 weeks and then again at 6 to 12 weeks postpartum to assess for early complications and then transition to lifelong health. With this, it's important to provide routine postpartum services, contraception, lactation support, as well as counseling. Helping Laura connect to long-term opioid use disorder services and ensuring that she has a good glide path for her care is part of this period, and then also supporting infant feeding, and that is part of the clinical team's role.
And then as the doula, we as birth workers know that the transition to parenthood is no joke. This postpartum period is something to take seriously. Supporting that transition is vital. Helping to connect this patient with different recovery services based on her needs, and supporting that infant feeding, which we're about to talk more about. Also, not on the slide here, but as Alex just said, helping this patient understand that pain is something to take seriously. If she's experiencing something new, that should be brought up with her providers.
Patients with opioid and substance use disorder often have dismissal of their pain. This is a quote from a patient from that qualitative study I mentioned earlier, where she said, "I felt like they didn't give much importance to the pain that I was feeling or what I was going through. I felt like they saw me as less of a human." You can imagine when individuals have this experience, they're reluctant to reach out, reluctant to come to the care team for support. A few content points we wanted to highlight. Can birthing people receiving medication for opioid use disorder breastfeed? Absolutely. Breastfeeding has many benefits, including supporting a baby with neonatal opioid withdrawal syndrome, and is safe. The maternal and infant benefits of breastfeeding, I'm sure, are well known to this group, and this holds true for this population as well.
So quickly coming back to Laura's case with these last few minutes here, where does a doula come in? Educating on the safety of breastfeeding while on medication for opioid use disorder, helping Laura find treatment options that fit her goals. Where does she want to be and how can she get there? And then connecting Laura with a postpartum doula again, or additional postpartum supports who can help her with that longer term support and who aligns with her in her desires for this postpartum period. Does she want to breastfeed? If she does, how can we help her with that?
So thank you so much, everyone, for coming today and being a part of our conversation. We look forward to continuing to hear from you and hopefully co-developing trainings in the future that meet your needs and help us to better serve patients with opioid and other substance use disorder. We have just a few more moments for questions, and then we'll move into our feedback session after that. Please, if you're able, use this QR code to give us some feedback if you're unable to stay beyond the session today. Thank you so much. And thank you to Julia for all of your work preparing these slides and being an amazing partner in pulling this together.
Thank you. As Alex said, I will be on if anyone has some more specific feedback or questions about this training development that we can answer. I am here for that. Otherwise, please, please, please fill out this feedback form. It is so very appreciated. Yes, I can put a link in the chat. And Avonlea, for the Q&A, I think we can go ahead and stop the recording and just have it as kind of a candid conversation instead.